Would ask that we approve those minutes. Okay, great. So the next thing I wanted to do is to go over the FAQs, to quickly ask questions, and we have 2 documents, and hopefully that's in the stack of things that are here physically and also was sent out to everyone. Yeah, there should be 2. Yep. Maybe we'll start with the patient guide first. Wanted to say a special thanks to Joelle Fati, who did a great job editing this and writing some. So for those of folks who may be joining by phone, don't have ready access to a computer, we're going over the FAQs for a patient guide, and starts out with this very broad question: what is telemedicine? And the definition is it's a fairly wordy definition, but it's what a lot of the federal folks like HRSA use. So telemedicine is delivery of healthcare services, healthcare-related information using equipment that can allow for communication between patients and healthcare providers, and even healthcare providers exchanging information to provide better and more healthcare services. This work is done using wireless technology like internet, satellite, iPhones, or smartphones. The use of telemedicine services can take place in many situations, including hospitals, clinics, homes, nursing homes, just to name a few. Comments, questions about that too? When we're trying not to be too verbose, it's often nice to refer back to what's been established.
I don't know how nice we want to be, but I mean, some of those technologies aren't wireless.
Well, I think we're just trying to say that, yeah.
Landlines, but
or satellite.
It feels like a scripture that we don't need. I would stop it. Not actually accurate.
What do people say about this one phrase, to provide better and more healthcare services? Any concern about that phrase, more healthcare services? I know there's a little bit of sensitivity about costs.
For me, I think about it as providing better access to high-quality healthcare services.
We're saying better access. Yeah. And the next paragraph says, why should I use telemedicine? We talk about convenience factor, to improve the opportunity to get healthcare closer to the home, convenient location, in a more timely way. And we just want like to explain it's just another way of getting healthcare, getting care from a provider.
I mean, it should, from my perspective, it's not always easy or convenient to get help for their health. I think it's not always easy or convenient for patients to get help for their health care needs. So it's health is kind of just a stop.
Care needs. So how's this, Senator Becker? It's not always or convenient for patients to get help for the healthcare needs.
Get their health care.
Stop right there.
Yeah.
So moving down in that paragraph, the benefit of telemedicine is less waiting and travel time and time away from work or other priorities. We talk about examples of telemedicine, such as a video chat healthcare, evaluation of a sick child by video, taking a picture of a skin problem into a skin specialist for assessment. And I do want to call out a link that Denny Lorden helped tracked down. And it's about a 3 or 4 minute video that it goes over what telehealth is. It's produced by one of the telehealth resource centers. I think it was back east. Denny, correct me if I'm wrong. And Denny was very kind to reach out to ask permission for use of this video, and they very kindly said yes. No royalties needed or anything. I think that was something we talked about last time as an option for a video. Denny, do you want to say anything more?
No, I think it's pretty basic and explains it in such a way that I think folks would easily understand it, which was what our goal was.
That's nice graphics. It has like one of those animated cartoon kind of thing. A moving picture is worth 1,000 words. Okay.
I'll edit just remove the comma between skin problems. Read it, it may seem like taking a picture of telemedicine, but it's taking a picture.
Okay. Any other wordsmithing or grammar? Much appreciated. Any comments about that paragraph on why patients should use telemedicine? And then we do briefly talk about the difference between telehealth and telemedicine. This is where talk about the ATA using those terms kind of interchangeably. That telehealth is a little bit of a broader term. Actually, I don't know if we say that. Whether you use the term telemedicine or telehealth, both terms can refer to the use of technology to deliver healthcare services.
Just last paragraph or sentence.
Yes.
Both terms can refer to the use of technology to deliver their services in remote locations. At this point in time, again, you're talking to deliver healthcare services. They can't talk services. Service locations convenient for you, comma.
Okay, so both terms can refer to the use of technology to deliver healthcare services to you.
It can be to you, the patient, but I think I would just take out in remote locations, because it can be actually.
Or healthcare services that are convenient for the patient.
So Denny said, your service. The next is a little bit about how common is telemedicine. I think this is mostly information here. Chris, any comments or?
Yeah, I guess a minor one. I might drop the cost-effective part and just call it effective. Partially because we're speaking to patients here, and so I think access is probably mostly what they're interested in. Also, I think there are some studies that are questioning the cost-effectiveness as utilization goes up.
Line is that?
Oh, sorry, I thought we just telemedicine space.
Oh, okay.
First line in that.
Joe's got it.
On last sentence,
Yes, any employers
I would remove standard at
added. Yeah, good point. Before we move on to this telemedicine safe, any last questions or comments about how common is telemedicine? Okay. Seen any? Okay, we'll move on to the next question. Is telemedicine safe? That telemedicine is a safe and an effective way to extend healthcare. It may not be appropriate for all clinical situations. A medical professional can help determine if telemedicine is appropriate.
Dr. Stark, I would, if I had my druthers on this, it would be telemedicine is a safe way to extend the delivery of health. How cost effective this is.
Right. I took out the cost. I just left in. Right now it says effective.
Okay.
That's what Chris was saying.
Okay.
Yeah. Are you okay?
Okay.
I think I'm okay saying effective. Yes. Cost effectiveness is all over the place.
That's a little duplicative of the first sentence in the next paragraph. We just borrow that first sentence.
Talk a little bit about guidelines and standards of care and reference the ATA telemedicine practice guides. I don't know if that's overkill for a patient, or they need to access it, or it reassures them that there's something out there.
I think it's
Yeah, thank you.
You want it, doesn't mean they have to click.
Normal.
Oh, no, think I'm not talking about, I'm talking about the sentence guidelines exist for safety and quality. That's already it.
I think you're right.
You could clarify that guidelines for telemedicine exist. You could clarify guidelines for telemedicine exist. Clarify, like all medicine, there are guidelines for this.
There's a little bit more information about patients. Where can patients go to get access to telemedicine services? This is where it's going to kind of be all over the map in general. In our response, I wish we could be a little bit more focused in this, but it's on your employer and where you live. Any advice how to maybe make this a little bit more useful?
Is broad, that's the issue. I don't.
Last paragraph is, do health plans pay for telemedicine services? That says health plans, including Medicare and Medicaid, are covering a wide variety of healthcare services available through telemedicine. Find out if your health plan covers telemedicine services. Please contact your health plan. Things about the ATA. Okay, so 1 point, yeah.
Back up to that one's fine, but give me an example of an online that offers telemedicine. I'm just wondering if people.
She pooped. She didn't know what to do.
Taking that as a endorsement.
Was there a comment that someone wanted to make, or is that just background noise?
Access on that services.
And I just want to clarify what Brody's question is. He asked, is there any wellness app, that last phrase, and the telemedicine services access paragraph?
You can stop at it.
Yeah. So I think that's maybe a little
Yeah.
down the road here. Okay. Brody, you had emailed me and expressed a concern about the grade level this is written at. And I think we're trying to shoot for a 6th grade level of reading. And there's a way in Microsoft Word to, when you do like word count, to see what it's written at. In fact, you're written at a 12th grade level right now. Which would probably mean we'd have to go back and tweak this a little bit more. And I think the sentence structures are probably a little complex.
I don't know the actual algorithm that goes in it, but maybe words like telemedicine, what's pumping it up?
Yeah.
I mean, there's nothing you can do about that. If you remove those words.
Is that
No, definitely.
no.
Background. So I just wanted to throw that out there. Just make sure that this is something that broad audience could read. Any concerns about the readability?
I think you're going to have the same issues that you have with a
Any
patient
technical.
coming in. They are going to make that may not be paid for. Again, we back to state. We'll have to be.
Well, I'm going to submit this to the whole group because I know there's some people who couldn't join us. But if I don't hear any other strong comments, what I would do is we're going to post this now to the website, and this would be something that folks could use, for their handout to patients or put on their website. And that was really the intention of this, and that you'll take and use. But we will make sure there's broad approval of this. Any last comments or questions on that before we move on to the next FAQ? Next, let's go to the providers. And I think with this one, we probably could be a little bit less concerned about the grade level reading. And I think what I'm going to do here is I will make sure that things sync up with the patient's guide. I think some of the questions are the same. For example, the first two, and I'll just, Phil and I will do a word match here. So maybe we'll start with this third question then, can clinicians get paid for delivering telemedicine? And this is where we reference Senate Bill 5175. And we basically just go through the provisions of that bill. We have a link to the bill that was passed. This is verbatim from the legislation. And I've just directly lifted what the Medicare health plans say here. I think it was Denny that wanted to add something about Senate Bill 5436. Just a clarification about home. Denny, do you want to say something a little bit more about that?
Just thinking a little bit more about that, it might be a little complicated to explain, but this was primarily geared towards the provider, right?
Right, correct.
So I don't know if we just briefly want to mention it in a one sentence statement, if that makes sense, that as effective January 1st, 2018, providers are able to conduct telemedicine visits to patients in the home.
For Senate bill and
Yeah, and then maybe if we've got the link there, I don't know if it provides any additional information for the provider.
Is it 5436, Senator Becker? I don't know how you keep all these straight yourself, but I'll double check now.
Maybe more, they flow better if you put that statements right there under, I don't know if this messes up or not, but under bullet B, well, as far as the following conditions, talks about the originating site is qualified, right, in 2018 to per Senate bill. Seems to fit within that, right?
That's why you have those devices, right? Here, Freddie.
Are we mixing CMS and private here? Trying to remember what's above.
No, they're kind of called out separately.
Okay.
We have a section that says commercial Medicaid in Washington State, and then down here it says following. Even folded.
Okay.
And then moving on to technology, and this is where we just emphasize having a secure encrypted video teleconference service that would need also standards that are laid out in the MCAC document. We've backed that like that. So, Mike, is there any plans for updating that or revising that? I want to introduce Dr. Micah Matthews from MBA. How about that?
For having me. So yes, with respect to the guidelines, the commission is aware that they were done for 5175. So there's a couple of definitions that are a little out of date. And so there has now finally been put together a work group, and actual commissioners have been assigned to it, and they're going to look at that and try and take a look at what the current best practices are out there, the various research, and figure out, do they need to update the guidelines. There has been requests from the community as far as institutions and vendors and whatever to get more clarity and something more substantive than just the guidelines. They appreciated the flexibility that they gave them to evolve, but they're now wanting some defined pieces. One of those that seems to be coming up consistently is practice across state lines in certain situations, like say Virginia Mason brought up a piece where they have folks that come in for bundled care, they go home, and it seems that for continuity of care purposes, it would be reasonable for the doctor or the nurse or whatever to follow up and say, patient so and so, how are your stitches? Are they sensitive? Are they seeping? Do they smell? You know, something that's related to the actual procedure itself. The commission is pretty clear that in those situations, we call it the UW model or the Mayo model. We don't care. Follow up, have good care. The other two situations are obviously we have border cities where, say, in Vancouver, we've got patients in Portland who have been coming over to Vancouver to see their doctor for years, and then they call them late one night with a massive headache. What do I do? Again, that's an established patient. Continuity of care seems to indicate that they should just be able to deal with them. And then the other situation would be the university student type of situation where you've been going to the same pediatrician for 16 years, you go off to another state, and you want to get a refill or talk. They've got all the medical records. There's no reason they should go to someone local if they've had a long history. So the commission's been quite clear on that. The issue is, one, other in-state regulators on their position on this issue, and then the sister state. And so not everyone's on the same page. So to try and address that, we're going to try and put forward a policy through the commission to basically say this is our policy and our position about this. We encourage continuity of care, and we'll give those 3 examples, and then encourage the regulators in this state to adopt that same policy, as well as push it out to at least the WWAMI state regulators of their sister regulators. So at least everyone in the Pacific Northwest is operating the same with respect to that sort of thing. The policy is nowhere near drafted. I only talked to our policy manager last night about that. So we're hoping to have it considered at the August commission meeting. It's about August 11th or 12th. Oh, absolutely.
Right. I mean, it'd be great to have comments.
Sure.
To look at it.
Yeah, we would love to get the feedback from multiple stakeholders for sure. But again, that's I presented on a panel with Representative Rodney at I believe what they called the Puget Sound in-house council work group, and basically all the hospital councils for the various systems in Puget Sound. And that was a recurring issue of, well, that's great that we don't feel that doctors have a problem with that, but you have nurses or other professionals doing that same cross-border issue, following up on a specific case, that is viewed as not as favorably by others.
Licensed, certified.
It's generally with the other state and the fact that they don't have a license in that state. So the example of bundled care would be someone that comes from Wyoming or Idaho. And so, you know, from our side, medical commission side, we're fine with doing the follow-up care as long as it's related to that particular procedure. But, you know, say maybe the nursing board or the board in Idaho or Wyoming would view that potentially as practice across state lines without a license. And so for that follow-up care piece, that's a very common thing that we would like to say, that's okay. You don't need to go and get a license because it's likely going to be a single kind of event. And if it escalates beyond the actual, say hip replacement, if it escalates beyond that piece, then yeah, you're going to refer to the local primary care provider. But it doesn't make sense to just drop a hip replacement in the lap of someone that didn't have anything to do with it.
So I look in integration of metal. So when you're looking at if you have an established patient in Washington, would that be considered in the same vein? Continuity care, because you have some levels of
right,
providers,
and that's the trick. And so I can. Oh, sorry. So I can't speak specifically to the mental health folks. I think that we're a little bit privileged as the medical commission because it's very cut and dry in respect to this sort of thing. So it's definitely something we would need to be working out. We are anticipating working with the various regulators in the state to make sure that we find something that can be uniform and equitable. And by all means, we would like the feedback.
So you'll be meeting.
Dr. Scott?
Yeah,
Would it be possible to repeat the questions, or I'm not sure if those microphones have to be activated or not?
okay. So I think the question that Senator Becker asked was about mental health integration and chemical dependency integration. And then I think there was more of a follow-up question. It's like, how long of a tail, you know, do we consider to be continuity of care? Is it 90 days? Is it a week? Is it a year? You know, and I think there probably isn't a great way to do this, but I think just getting some kind of guidance would be really helpful.
I would even say that some of the questions apply to the front end of it as well, not just the tail end. As far as one of the examples you gave was a college student who's out of state. I mean, if they have a doctor, but they haven't seen them in like 3 years, does that count as well? So I think the definition of what qualifies as established patient and the tail end of that, I think the follow-up of an episode of care, that makes a lot of sense. There's not really a question about the beginning, but when those other examples that you gave, I mean, it is more convenient to go see the doctor that your family has, but if that person actually hasn't seen that doctor for a while, that works as well.
Right. All good points that need to be addressed for sure.
Dr. Scott, I'm sorry.
Yeah, go ahead.
I just wanted to comment that for those of us who run telehealth programs and are working with new providers, these are the kinds of questions that we don't always have answers to or are not familiar with. It would be very helpful if we could take some of those scenarios that you outlined and do an FAQ kind of thing for a provider, because I myself don't understand it. And I don't know I don't know if these guidelines are in development or need to be fine-tuned a little bit, but that would be particularly beneficial for myself.
I think we could classify them as the earliest stage of development.
Okay.
And
Well,
Jenny, there is a possibility of public comment. Yeah, Mike has said he'll be sending them around this summer, and everyone in the collaborative will have an opportunity to weigh in and ask questions.
perfect. Thanks, Micah.
I'm just going to put
That a little bit. Border cities, I think, would be a particularly interesting case for us in KP Washington because we have a small number of patients in Idaho who get their care in Spokane. Exactly what we described. They may show up in Spokane, get primary care, go back to where they live nearby in Idaho, and then if we want to refer them, for example, endocrinology, are we allowed to have that be a virtual consult, or do they have to come back over? And that's exactly the part that.
Right, and this is the work on developing this guideline, or I'm going to just call it a policy, because the plan is, and I'll be specific, but policy development for the medical commission. In order for us to do that, the commission can approve it, and then they send it through to the secretary's office and all these various steps for review to make sure that there's all the eyes on. We want that, so just to make sure that everyone's weighed in and that we've got something that's a good product, but the hairy aspect of the border cities is definitely, I think it's more unique to Washington than not, and it's something that we have received questions about.
Maybe if we could just hit a pause, Mike, and we'll come back because I just want to make sure we can get to this document. And there is still something that I want you to see. The next issue is about consent. Do you need a special consent form? And this is, again, taken directly from our report that we put in I think, December to the legislature that Adam Romney had helped us go through. And then the second paragraph there is almost directly lifted from MQAC guidance on this. I know that Mike Farrell at MQAC is maybe reevaluating this. So if there's any changes on what we need to do for consent form, we'd love to hear what you're thinking about that.
I'm not sure if there's any anticipated change about informed consent. I know that with respect to the ATA, they gave us an F on informed consent for their state rating, and Mike Farrell and I were both really confused about that because it seems like it's pretty clear and open. As it turns out, they actually referenced a very old document that we weren't even sure how they found it. And so that's not taking into account what's actually in the guidelines. They've referenced something old. That was, luckily, I think that was our only derogatory remark as far as telemedicine friendly in Washington.
May I ask a question on informed consent? I happen to believe that informed consent covers you in a lot of different ways. But how would, if you're doing this by telemedicine, it's, eye doctor and me have reviewed and discussed the information, blah, 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 yes or no. Would then there have to be an acknowledgement that I, patient, consent to, because you don't have a written signature line?
Most consents that I've seen online, you can either click this box and hit agree, and that generally suffices if you've read through it. The joke is the biggest lie on the face of the planet is I have read and agreed to the terms of service. So I think we will probably end up with some of that as an issue, but I believe there's no statute in Washington that requires any sort of a wet signature anymore.
Yeah, you actually don't need to sign. You don't need to have sign informed consent for even a surgical procedure
Anymore?
No, it's often the standard of care. A lot of healthcare facilities because it's more of a QI process. And when I've talked about this with our attorneys, they said, telemedicine is not like a new procedure. It's not anything like that. It's the standard of care, just delivered in a different means. So I think they've said, as long as you have these discussions with them and you document like you have here, then that's fine. The other thing that I've heard is also often used is just an information sheet that can be mailed out ahead of time. And you could say the patient had reviewed the information sheet and we asked if they had any questions. They said no. That might also be fine. Yeah. Okay, hang on right here. Hang on. So then there's some language on how to document your visit, and I think the key thing here is just that sentence that is conducted via a bidirectional video telesession. Whether you want to add the technology, the 128-bit AES encryption is up to you. You might actually have 256, but 128 is considered to be the standard. And then a little bit about how you can get more information.
Do we need to, maybe Lisa could chime in here, do we need to put place of service and modifiers and talk about that here or elsewhere?
You know, Danny, I think that's such a complicated moving target. I think it's more likely to confuse people. Mm-hmm. And I know we have some time for Lisa to bring up some of these issues later on. My suggestion is maybe we not put it in this FAQ.
Yeah.
It's getting too much in the weeds, I think.
And I think you probably covered in the next paragraph, where can I learn more? They could answer those questions.
Thanks. Okay, well, great. So we're gonna next say hi to Dr. Ziebelman. So I just wanted to let folks know that Julie, who used to be at Multicare and is on this phone call, has moved on from Multicare, and she had kindly suggested that Dr. Ziebelman replace her. And so we wanted to take this opportunity to get to know you a little bit better. We do have his CV that was sent out, and it's on the table in front of you for folks to review. But we just wanted to give Dr. Ziebelman an opportunity to introduce himself, and if you could just tell us a little bit why you want to be on this committee.
Hello, everyone. Nice to be part of the group and to meet everyone. Why I want to be part of the group is I just started my role as medical director of virtual health for Multicare, helping them set up a virtual health system and modalities to be able to treat patients. I also have an interest in telemedicine for over the last 5 years, doing some international work via telemedicine, as well as being part of a startup that was creating a platform, and also working with a second company as an advisor. So the interest has been growing for some years, so I find myself in this position, and it makes sense to represent Multicare here at the collaborative.
Great. So, when we formed the collaborative, there were certain groups that we wanted to represent. One was a large hospital system, and Multicare, the large presence was selected at. And I think we talked last time how membership goes with one's organization, for the most part. And I would like to entertain a motion to have Dr. Ziebelman formally join the collaborative. Second?
Second.
Wait. Any discussion? Okay. All in favor?
Aye.
All not in favor?
That's
Okay, great. Well, welcome, Dr. Ziebelman. How about that? Great. So the next thing I wanted to turn to, and the reason why we're down here in Olympia, is to really dive into the Federal Interstate Compact. So I want to turn it back over to Micah, and if you could just maybe just start out, basically, what does the compact say, and what are the next steps that we need to do as providers, as insurance companies, as health systems to kind of implement this?
So again, thanks for traveling down, and for those of you who are already here, thanks for coming over. The compact is basically expedited licensure. That's, for any of you who have talked with me about licensure issues, you know that for the medical commission, the licensing group reports to me, and I've got this long shot dream of 0-day licensure at some point. This helps us get there in a way. But it's not, I won't say that it's the silver bullet. Not everyone wants to work in multiple states. but there are many who do. Radiologists, pathologists are one. Virtual care is definitely one. And even UW, I believe, has a psychiatry program that they're wanting to expand out. So it's those groups that it does help. Given the fact that we are now all the WWAMI states except Alaska are part of the compact, it's going to help with training and well, Oregon, I don't believe is part of the WWAMI.
No, but I mean,
Okay, yes. Right. So they're not, that poses a little bit of a barrier, but it's still one of the things where it makes it a lot easier to send and receive licensees and trainees. So the main thing that I've watched take shape with the Compact Commission itself is that they are really focused on making it a one-stop shop. You go to one portal, you fill out one application, and you pay the fees to have the home state of the state of principal license, which is we're calling it SPO. They then get told, here is this applicant, please verify that they meet all the qualifications of the compact license process. They conduct that verification, then they send what's called a letter of qualification, or LOQ, to the compact for distribution, saying this person meets or this person doesn't. We'll just take this person meets its qualifications. At that point, based off of whoever the licensee chooses to select, that's one of 20 states, although I will say that I believe not all 20 are active at this time, and I'll get into why in just a second. The letter can be submitted to all of them, and the receiving states, who are not the state of principal license, will issue the license on an expedited basis. So in the real world, the way we've seen this work out is it takes less than 5 days. So the first one happened, I believe, April 19th. It was from Illinois to Colorado, and the time frame of when they issued the letter of qualification to the point of where Colorado issued the license was 2 days. So for those of you who are familiar with the licensing process, that's pretty phenomenal. So
just for reference, it's about 3 months. And that's been my experience to get a new license, and having done it in 2 states now.
Yeah. So I was stunned to hear that was the actual time frame. The time that between the time that they started the application, got everything verified, and then went over, I think it was a grand total of 14 days. So most of that time was on the home state verifying thing.
So, Mike, if I may ask, because having done a lot of, the application process, what happened to the regulation that they needed the primary verification? So the hospital required, and I'm assuming it was based on something, primary point verification from the schools and residency program.
Okay, so that is being done by the home state, and so they're basically, because they would have already had all of that and verified it, and so they are easily able to go back and say, okay, here's the licensing file. This is what was verified at that time. So I mean, your school's not going to change. Your residency won't change, because these people will have been in practice for at least 3 years. And so really what they're doing is they're checking the National Practitioner Data Bank to make sure that there's nothing new as far as derogatory remarks there. They will have done an FBI background check, which usually will be the time-consuming factor there. Although applicants can do that ahead of time and save themselves some time.
So my question, and if I may, just real quickly on this, so they are going to be able to utilize the NPI. And can all of this primary point verification be kept at that level, at the NPI?
The National Practitioner Identifier?
Mm-hmm.
I'm not quite sure what you mean by that, ma'am. My understanding of the NPI is that it's used as a billing tool for CMS. Is that?
It's a national identifier, right, and it is a billing tool, but I was often frustrated that even though we had submitted all that, that we didn't have one point that we could go to for, because we'd have to go back to each of the schools in the residency programs to get those primary points of verification.
Right. So that would have already been done in this case, because with the state of principal license, they already have that license, and the licensing authority or the regulatory authority there would have done that already. So they've already got all of that primary source information. If you're talking about credentialing for hospitals, that's a different conversation. This only deals with licensure though.
Okay, I appreciate that.
But I, having had some family members just go through the credentialing process, I completely understand what you're talking about there. So
I'm just thinking, since it's gonna go across state lines,
Yeah.
the NPI would be the perfect place to keep all that primary verification so that the compact could get.
right. So with that, I'll go into some of the hurdles that we've run into. I would say number one with a bullet is FBI background checks. There's been numerous conversations with the FBI about the ability to get those, to access those, who has the authority to do it. And some states don't have the authority written into statutes to collect and retain those things. We are not one of those states. I believe we've had it since at least 2006. And so the issue at this point is how do we do it faster? Currently, we're sending these cards with a special code on it to anyone that has an out-of-state address to get fingerprinted, and we don't fingerprint in-state folks because we use Washington State Patrol's background check. But in this case, everyone that goes through the compact has to have an FBI background check. So what we are looking at is doing live scan, which is you go in and you scan your finger. It's kind of like TSA, where you get pre-checks. And so it's a digital transmission, and it conceivably will make the process work faster, and will eliminate the mailing of the card and mailing it back. Were there other specific questions that were needed?
Maybe I can ask about fees. So maybe walk through a hypothetical case. I'm licensed here in the state of Washington, and I want to start doing telemedicine to Oregon and Idaho, Montana. So I submit, I pay my fee to the Interstate Compact website, whatever. Do I have to pay a license fee in all three of those states, or is there just the one universal application?
Okay, so the Interstate Compact does not impact the fee setting ability of the individual states for their license. So the license fees for the states are all the same. You are paying a one-time application fee to the compact for them to basically coordinate with the state of principal license and manage the portal and all that stuff. And so that, I believe, is $700. It's just a one-time, that's it. You've got all your information there. The letter of qualification, there's a transmittal fee, which is good for a year. So if you want to repeatedly send your letter of qualification to different states, that's that fee there. The other piece of the cost is the individual state license fee, which you do pay to the compact as a one-time, as a one location payment. So you're not going to each individual state and paying a fee. It's all one place. And at the end of the month, the compact then disseminates it to the states where the licenses were issued.
That's going to be a big check.
$1,450 on the website. You can't do Oregon.
Is there any talk of standardizing those fees in the state?
There's some talk here about what our fees should be. The $700 fee is part of it goes to the compact, part of it goes to the state of principal license to cover the work of that. So we're not charging anything extra to do that. I know that in my mind, I think because of the qualifications of the practitioners that they have to get into the compact, it's sort of a premium of the crop situation. I feel like we could probably do to lower our fees for that group. And that's a conversation that we're going to be having forward with the implementation team.
Do I have to use this?
No.
So say I want to, again, I only want to go to Idaho and I want to have to pay the $700. I don't care about, getting it in 2 days, 3 months is fine.
I would say just use the standard route.
Okay.
So just clarifying about the process, I'm looking at the website. So if I were to do this, I would first get my Washington license through my normal means. I would additionally do this, but extend that to other states. Does that work, or do I do it as one process?
I'm making the assumption that you've been licensed in Washington for 3 years. Okay, so yeah, then if you're going to go to multiple states, let's say you're with UW or something, they say you have to be in all the WAMI states. Okay, fine. Go to the compact and pay the one-time fee, and then you have them have Washington do the state of principal license, and then have your letter of qualification transmitted to all of the WWAMI states and they issue the license.
Any questions from the network, folks on the call? Got the expert right here.
As I look at the map, the big misses are Oregon. That's ending there, right?
No, if you're familiar with Oregon statutes, there's some information sharing blocks that happen there. And so we're trying to work through that on the PMP level, even just for sharing Oregonian data. And so that's been a little bit of a snag. With respect to the 20 states, this is a good segue to do that. The ones that are not immediately up and running, issuing licenses are number one, Washington, because the law is not effective until the 23rd. So we are working on developing messaging and communication and websites and everything to get all this stuff out. Social media campaigns. And then the things that we really need to address are, number one, streamlining the FBI process. And the other piece would be the renewals, because the renewals for other states are a bit different. We do it on birth date. Other states, like say Wyoming, there's 2 weeks in the summer where they hire a bunch of people to come in and they renew everybody in the state. Well, it's good for 3,000. For 33,000, it gets a little ugly. So it's nice to have that just steady piece of work so we can not get surged. So those are the main things. So like Minnesota, they're one of the ones that are snagged on the FBI retention piece.
So Micah, can you clarify, is Oregon a signatory?
They are not.
They are not, okay, I'm mistaken. Yeah, I knew Alaska was.
I know that I've talked to the executive director of the Alaska board. They are very much in favor, but they are in a pretty bureaucratic model. And so their supportive concerns aren't getting out of that agency.
Representative Schmidt?
Thanks. I'm just curious, what other hiccups have you had along the way, at least telemedicine side? You understand the compact idea of multi-state license. What are you seeing? What are you experiencing otherwise? I mean, is it something that the legislature needs to address, or what?
Are we talking in the context of the compact or just generally?
I'm talking in really from telemedicine standpoint.
There's, and just by way of background, I go to an organization called CTEL just because every fall they tend to present some peer-reviewed research, and it's almost like a CME conference for telemedicine. It's pretty excellent stuff that they present. And so some of the research that's coming out has been referenced with respect to, telemedicine maybe is not an overall cost down driver, but it does seem to be an increase in utilizing. The California Medicare study, Medicaid study seem to indicate that. There's also some concern with, the app-based medicine pieces that I'm really strongly recommending to the commission that they don't take a position on that. And when I say app-based medicine or mHealth, what I'm talking about is beyond WebMD. If you're offering a diagnosis, if there's some sort of a ability to prescribe or anything like that, and it's based in an app, then we need to leave well enough alone. And I was able to get confirmed last month from a lawyer that consults with the FDA and the FTC that anything that's diagnosis-wise in a mobile device, they consider it a durable medical good, and the FDA will review it and approve it, which I was sweating bullets until I heard that. The other piece is dubious claims, and that's the FTC's Consumer Protection Division. There was a company called Luminosity that was cited by the FTC by saying you are making claims that you can't back up and there's no way you can prove it. I was shuddering to think that the medical commission was going to have to somehow address that. In my opinion, it simply isn't possible. We don't have the staff, the expertise, the reach, nothing. So that I'm glad we were segmented away from that. What we are hearing is much of what we discussed earlier with, how do we deal with these border situations? How do we deal with these established patients in other states? And so commercially, the compact is addressing that, but there's I think it's what we're going to hit is the one-off conversations about I'm a solo practitioner or whatever, and I've found this really cool way to offer more services or pilot this thing out, and they just may not know the rules, and so that's really where it was helpful for 5175 to establish a definition. It was helpful to the home thing I was wild about, and so those clarifications are great. The request I think now at this point is that the commission clarify their guidelines and update it. And if there's rulemaking to be done, I'm not sure yet. I would rather that we not get too concrete, but that is also the request that we're kind of getting from vendors. They want some guidance about what is a physician or a medical practice to do. So I understand both sides of that. I would like us to be moderate and just kind of be generalized if possible and satisfy the party.
Previous claims makes me think of fraud.
Yeah.
How do we avoid that? I mean, truthfully, that could become. I don't want any, and this has been my concern since day one. Is how do we make sure that we're not setting providers, physicians up for being accused of being fraudulent in their activities?
In that case, that enforcement might be done for us with the Federal Trade Commission. They have been extremely active in looking into these sorts of things, especially after the Sherman decision. They really have been active in many states about that.
So that's reactionary. Then how can we become proactive?
I think in the case of like luminosity or wherever, they were right. They were making claims to patients that there was no way they could back up. One notable example is the dermatology. I don't know if you're familiar with that dermatology out of, I believe, University of Philadelphia Medical School, where they just had vignettes that they had medical students have, and they got pictures of dermatological stuff from a Google search, and without a two-way communication, they just submitted these fraudulent pictures, fraudulent IDs, and not only were they getting diagnosed and prescribed, they were misdiagnosed. And I mean, it was one of those things where you've got that, but on the other side, when people are trying to actually test accuracy about diagnosis, they're having to use burner phones, burner credit cards just to do it, because the companies are seeing these common things that might be linked via IP address to the medical school, and they know that they're getting studied, and so they shut it down. So that's not typically the way that a quality vendor would usually approach something.
I think it was UCSF. It was in JAMA Dermatology. I think the other concerning things about that study was how many of the guidelines, the ATA guidelines, they were like not even paying attention to. They did like a secret shopper kind of thing, and yeah, it's a real wake-up call for the quality assurance that needs to take place.
I mean, I think I still come back to when we're talking institution to institution, consultation, institution, consultation clinic, even live two-way video patient to practitioner. I think those are all pretty safe. It's when you start getting to, I didn't speak to you, I didn't see you, it's an app on my phone, it's not covered by insurance, it's not part of my insurance policy or my institution. That's when we're opening some doors.
So Micah, how close are we to having one license for the whole United States? Any thoughts on that?
About 29 more states. No,
halfway there.
Yeah, I mean, I do view the compact license as kind of a form of one license without having to disrupt the statutory framework of 50 states. And so that's conveniently, that's kind of the way it's viewed at the people that show up at CTEL too. They view the compact really as a single license, a simple way to do it.
And for those of you who don't know, we're actually already doing this for the Department of Defense and the VA. So you just, even I can be in the VA facility in Virginia, but if I'm licensed here in Washington State, as long as it's current, I can still see VA patients in any of the 50 states. So that's worked out fine as far as I know.
Yeah, there are implications of when they go off of the or DoD sources. So it's notoriously difficult for us to get information from DoD VA if there's an investigation or a complaint. We just simply don't typically get that information. However, I will say that there was and I'm blanking on his name now, the medical director of the VA amputee group, and he was asking, if they were prescribed tablets, would they be able to do that? Because he was licensed in New York and not Washington. And we kind of just looked through it. We're like, you know what? They're prescribing the tablet. They're providing the tablet. That's an extension of the facility. So we would view that as just they're working at the VA facility through telemedicine. We were able to craft a letter, give it to them, and they wanted to take it to the various other venues. Apply.
Since we're talking about the CTEL conference, my colleague also attended, and one other thing I wanted to share about that is a rising disparity between Medicare policies and reimbursement and what's going on at the state level. When you're an innovator, that's great, but I'll just let you know that from an institutional perspective, this is creating quite a bit of angst at UW, because we often take Medicare as the gold standard for how we will charge people and how we code, and to really create different policies for different payers creates a lot of work around. And to that end, they talked about how there's probably not a lot of optimism, I'm hearing, about any kind of reforms to the Medicare law, specifically about the rural restriction. So just something, though, for folks to be aware of. Did you want to talk?
So if you're familiar with CTEL, they've got quite a few different genres of folks that show up. And one of the big focuses that they're doing right now is putting together a group to find, vet, put together, and submit to the Office of Management and Budget in DC, basically research and evidence that shows that they're scoring telemedicine wrong. They're not taking into consideration that things like if you get more access to care, you have less ER visits, that kind of thing. There's a lot of frustration, I agree, in that room that OMB is not doing it right. But they also recognize that in the 90s when they...
The acronym, I'm sorry to interrupt.
Office of Management and Budget, or the Congressional Budget Office, CBO, sorry. So yeah, the Congressional Budget Office, when they scored this same sort of bill in the late 90s, basically the rural piece was created, which was good, but they don't take into account anything that's downstream. No potential savings, because they're only looking basically at the encounter and then 1 degree of separation out, and not all of the other stuff as a system. And that's just been a real frustration, even to the regulators. Like, we think that patient access would be great. You're going to avoid all these things. Why don't you think about this? And that's just a lack of understanding at CBO. And so the point of this group is to take these folks who are willing participants, researchers, academians, and vendors and whatnot, get relevant peer-reviewed research, even develop study models, and educate and convince CBO that this is the way they need to be looking at telemedicine scoring. So in the future, when they get a telemedicine bill and it says, oh, it'll only save, $10 billion, when in reality, the downstream cost, it might save $50 billion. So that they're working on that. They're hoping for an October submission on that. I wouldn't be incredibly hopeful there. It's because they presented their meta-analysis, basically all the stuff that they found, and they found 500 potential studies, and it went down to, I think, 10 after using their criteria to kick out the stuff that didn't apply. So there is a bit of a lack of study on this.
Yeah, I think it really speaks to not only the lack of study, but the lack of quality studies in the field. Despite this, there's 2 good journals and there's lots of studies out there.
Ask a clarifying. So they're going to submit to CMS?
No, the Congressional Budget Office, because
To the Congressional
CMS loves telemedicine and would love to do more of it. The problem is whenever it gets attached to a bill, Congressional Budget Office scores it, as I said, they look at the encounter and then just 1 degree of separation, and that's the only really savings that they're looking at.
Do you think CTEL would be willing to share that information that they're going to send to CBO, whatever it is,
CBO.
with the state, so that we could take a look at it?
It's
what
actually
you
a
just said
national
are some
group.
of the arguments that we got. We didn't have anything that could back it up, and it went nowhere.
Yeah, it's a national group from various states and universities that are looking at it. They've been going for, I think, 2 or 3 months. I would anticipate that September is when they would have something to share that if they've got an argument. They are, like I said, hesitant to repeat the mistake of the 90s, where if they don't come out with and educate the right way, it could hurt us more. So I think really it comes down to, if they have a workable product, they'll go forward. If they won't, they will just wait until the right time.
Yeah, so both the University of Washington and Micah and the MCRAC group are part of that group. So I think between the two of us, we'll make sure that at least the members on the collaborative know about that. Yeah. Any other questions for Micah? Okay, great. So the next I wanted to talk about is Lisa Roche had a letter that she wanted to go through. So Lisa, I'm going to turn it over to you. And for those who are here, it starts out, Dear Health Insurance Carrier. And so Lisa, if you could kind of give us, first of all, before we go into the letter, like give us a little bit of background as to why we should consider this letter.
About, oh, can you guys hear me? Hi, can you hear me?
Yeah, speak up.
Sure,
we can barely hear you.
Sorry, the letter came about as part of a discussion about making sure that the payers in Washington are aware of the upcoming legislation allowing home as an eligible originating site, and also verifying the difference between the billing policies between CPT and Medicare, the 95 modifier versus the G2, Medicare's new requirement for place of service 02. Do they allow the standard consult codes versus Medicare's telehealth consult codes? And so we just thought that it might be not be a bad idea to, one, make sure that the payers are aware of the upcoming legislation so that they can prepare their billing systems to properly adjudicate the claims, and not get denials and then go, oh, whoops, we need to fix this after the case. And then just to get a clarity on their billing practices. Well, how do they want us to submit the bills so that they only have to process them once and we only have to submit them once? So that was kind of the premise of the letter.
Thanks, Lisa. I can't emphasize how much time we're spending at the UW trying to figure this out. And this goes back to the differences between Medicare and commercial plans and Medicaid.
Exactly, yeah.
Yeah, so I just want to second the sentiment that we really are looking to Medicaid and plans to.
And Dr. Scott, it just seems to me that if possibly we sent this out from the collaborative versus each of the individual institutions or health systems or telehealth programs, we might be able to be much more effective at sharing that information and asking for it one time.
Yeah, that's why it's, you know, even though Lisa wrote it, my name's on it. So, Brody, I know you're the only representative from one of the payers today. I don't want to put you on the spot, but I don't know if you could respond to this. Is this something like this possible? Oh, of course, yeah. Please forget you wear many hats there, Chris. So Chris and Brody, we'd really like to hear your thoughts on just helping us with a little more clarity on that.
Just in scanning the document, I don't have any concerns in our plan receiving this letter. Yeah, I mean, just the quick response is that we use the GT modifier, not the 95, and we do recognize the O2 in our reimbursement policies even today. We do recognize home as a originating site that's acceptable for receiving telehealth. We're very much pro telehealth and telemedicine in our company, so I don't see any concerns. We are updating our reimbursement policies effective to more clearly spell out what is in our reimbursement policies today. But I don't, as we do call out in our new reimbursement policy that O2 is an acceptable place of service, for example. So.
Brody, this is Denny. Do you think we're asking all the right questions or enough questions?
I haven't, I don't think we are, Danny. I think the one thing that we have already in 5175 is that we'll pay the professional and technical component and not the facility fee. And there's questions around the facility fee and the technical and professional component. And I'm not sure how to put that in verbiage, but I think we need some clarification around that as well.
That the technical fee around the originating site setting up the patients.
Right. Initially, when we started in telemedicine and the facility fee became a big area, I actually opposed the facility fee if you're looking at it in the same context as a hospital can charge a facility fee, but a provider can't. But then when you look at how do you break a CPT code apart so that the originating doctor who has the patient in their office and now they're doing a telemedicine visit, that the professional component would stick with the provider they were in essence consulting with or having that initial. But then you have the provider that has them in their office getting paid for that portion of it. But as this breaks apart, that facility fee, it should all be addressed in how we're looking at it.
Yeah, so I don't have the exact code, but if the site is the home, right, where there is no doctor at the originating site, then that doesn't apply. But to the case where they are in a healthcare facility, there is a Q code that I can't see. Yeah, 3014. That's in our policies today to bill that from the originating site.
And there were real problems around that, if I recall correctly, when we were in Tacoma, that they couldn't differentiate between who was the originating site and who was the distant site. So I think that this needs to be thought through and put on it.
Chris, or I think we have Francis on the line as well. Francis Goff from Molina. Any responses to the letter going out and having a generic response from all the payers?
Yeah, I'll go first. So I have a couple of thoughts. One is just in terms of the mechanics of it. So one thing, at least in the current year, when we were Group Health, now migrating to KP Washington, we took a slightly different tact. And so we had specific CPT codes, because there are also some generic CPT codes which apply, and we were using those rapid modifiers. So I wonder if we should leave a little more options in terms of, fundamentally the question you're asking is, in what way do you want things submitted so you recognize them? So it's a little bit of a narrow framing of the question this way. So maybe just broadening that, really just say that, how do you want these things submitted so you recognize them as valid billable visits? These are some options, but you may have another way as well. And we may find some variation there, and I'd love eventually to standardize that. That would be great.
Yeah, we do have those codes as well. I was specifically referring to which modifiers and place of service, but we have similar.
Right. So I think that's part of it. And the other part too is, I think, implicit in the question of, is this, how do you bill for the service? Is it a billable service? And so I think there should be something in here asking, what requirements would each carrier have to understand it as a billable service? So there are, for example, we've defined our own documentation requirements, and there are certain things in global period issues. So there's a lot of detail that goes behind that around, is it even billable to begin with? And there may be variation between carriers, but I think this letter should ask for that as well.
Yeah, I'm really envisioning that the collaborative might be able to have a table from all the payers, and we could put in like, okay, this is what is considered to be a billable telemedicine visit, and this is how you should document for KP versus regions versus, you know, some of the other payers.
And even better, we all.
It'd be great if it would be standardized.
That would be nice.
But I understand that sometimes people have a little different takes on it.
Just a question, how do you share that information with the providers if they want to do telemedicine, those requirements? Is it electronically sent out to each and every provider regardless, or?
Yeah, I think at least within KP for our contracted network, so for our internal docs, sort of moves. But for our contracted network docs, there is a communication that I'm trying to find it now, but I haven't found it yet. There is a document which outlines everything I just described. It says here's what we expect for these, for a video visit, for a forward visit, for whatever. This is what we expect.
We have a public-facing website. Anyone, even beyond doctors, can go.
And they can see the requirements. And so,
Francis, what about Melina? You
Would it be beneficial for the collaborative to approach all the carriers, you know, in the state and just ask, in order to utilize this technology, what do you think of the possibility of outlining, because you were talking about standardization, and I know every carrier is going to be different, but maybe there would be a few things they could agree on and actually be able to put that out there. These services are available, you know, electronically. It might be worth a question. I don't know where that conversation would go, but it wouldn't hurt to ask.
What do you think? What do people think about this letter having a ask or a request that, you know, could you all get together and standardize, or we could at least agree on 3 or 4 important things?
I'm just remembering back to 3 or 4 meetings ago when we had some discussion with payers, and there was quite a bit of confusion around the issue, maybe not understanding either telehealth or their own related policies. I'm just welcoming input on where folks think they might be today.
This is Emily from Care. I know at least for us, even just a simplification or an agreement around CPT codes, you know, in alignment with the ones that Medicare has already published as eligible for telemedicine, would make things a lot easier for us.
Thanks, Emily. Was there someone else who wanted to make a comment?
This is Lisa Roach. The only thing I would add to that is an alignment with Medicare codes would be great. I mean, it would be ideal to have one set of codes. The only thing with my concern with that would be that an alignment with Medicare codes would also be limiting the codes, because if you look at that Medicare telehealth fact sheet, there's, I think, 2 or 3 pages of codes that they allow, you know, and like, for example, admissions aren't on that list. And so my only concern is if we say we want you to follow everybody to agree to follow Medicare, we might be limiting coverage unnecessarily. So that would be a concern.
I agree. Other comments or questions about a letter here? So I'll let people think about it, but what I'm hearing Senator Becker say is, you know, if there could be a little bit more specificity about particularly the pro fee and the facility or technology fee, and then a request that Representative Schmick made about, is there a possibility of standardizing some of these policies?
I don't know if you'd ever get to standardization, but I don't think that a conversation would be, I would hope it would be helpful.
Would it be possible to have it kind of be a 2-phased approach? The first phase being the information gathering to see how similar or dissimilar the policies are, and then based on the information that's gathered, look maybe as a second phase to promote, you know, similar policies. If we find out that the vast majority of them are doing it a certain way, we can share that with those what I'll just call outlier plans, for lack of a better term, and say this is what the majority of the plans are doing. you know, for ease of administration of this service and the billing and what have you, would you consider, you know, being more aligned with these other payers in your policies? But I think it's hard to ask for, you know, them to collaborate till we really know what they're all doing.
Yeah, it's a very good point. What do people think about a two-phase approach? And a lot of head nodding here. Okay. So maybe we, maybe table the standardization question until we kind of see, you know, maybe that they're actually 5%.
Would it make sense to add Senator Becker's items in there, and then maybe this group could review it again before it went out?
I think so.
We always listen better if we hear it twice, right? You know, I keep thinking about their contract, and maybe Brody, you can help me, but are your contracts for, I mean, you know, you may be one carrier, but you'll have 12 different plans, out there. Are they going to all be individualized on this, or are they going to be pretty much elements?
The policy applies to all commercial. So, I mean, the rates may be different on policies.
Okay.
Great. So that's pretty much it for our business that was on our agenda. Wanted to open it up to the public and see if there's any questions or comments, and then maybe wrap up with some housekeeping for like next visits and topics. But if you could please just stand and introduce yourself, and if you want to come over here, just sit over here and open the mic for you.
Good afternoon. My name is Leslie Emmerich, and I'm actually here representing 5 clients today. I have the Washington State Hospice and Palliative Care Organization, and I'm going to talk a little more about palliative care and telemedicine. The Home Care Association of Washington, which is home health nurses. The Washington Home Care Association, which says private duty nurse or private duty home care, and then ARMPs United of Washington State and the Washington State Psychological Association. So all of my clients, except one, have a interest in telemedicine and how it rolls out in Washington State. One of the things I wanted to talk a little bit about were the relationships about home care related issues. I remember a couple meetings ago, Senator Becker, you had mentioned something that you had some concern about how home care was going to offer this. And there was a couple things that popped up for me at this meeting today. One of the things that I've seen done with home health agencies is telemonitoring. And how will that fall under telemedicine and telehealth? Where you have perhaps weighing people, checking their pulse, blood sugar, there's lots of different stuff. The doctor here would know. There's a lot of things that we can do through telemonitoring, and a lot of times these telemonitoring stations go to a nurse, and a nurse sees, oh, Mr. Jones, you have high blood pressure today. What's going on? Or you've gained 5 pounds. What, for Chinese food last night? You know, I mean, whatever. And they'll be able to flag that there's a problem and then initiate a visit. So that's kind of the telehealth bill that we passed a number of years ago with the Healthcare Authority to get reimbursement on. And where does that type of telehealth monitoring fall into telemedicine and billing and those sorts of things? Another thing, I'm also through the Hospice Association and the Home Care Association of Washington. I participate in the Department of Health Rural Palliative Care Initiative. They have an entire subgroup on telemedicine. And I don't know if this committee would be interested. Pat Justice here at the Department of Health leads that committee. But it seems like a lot of the work that they're doing in the rural areas to help expand healthcare in places that are very rural and don't have a lot of access, so that people know about advanced directives, they know about palliative care, and they know about end-of-life care. that might be something you might consider as a presentation to this group at some point. I don't know if that's kind of the scope of this group, but very interesting conversations that we had about that. And then the billing piece for palliative care, it's kind of one of these weird things that falls in between home health and hospice, and some people can't even figure out where to bill for it, and they just do it because it's the right thing to do. So that's an issue that we have on the federal level as well, and trying to figure out how to best bill for palliative care, and especially palliative care that's done through telehealth. And I think that's all I have to say today.
May I just ask you a quick question?
Sure.
So when you're talking hospice or palliative or home health care models, ARNPs, of course, are licensed, but in the psychiatrists, but the others are either certified or no.
You're talking about home care aides. That's different than home health nurses.
Yeah, and so when you're providing hospice, palliative care, and home health nurses, are they contracted to the state? Or are they paid through the state currently? How are they paid now?
Some are. Some have Medicaid and Medicare contracts, and they're hospice doctors that actually work. They're part of a bundle, a team approach when a hospice goes in. So you have doctors and nurses and social workers and chaplains and hospice aides. They're all part of a package that goes in and serves a client. So my guess would be hospice doctors, potentially ARMPs, that would be doing the palliative care type work. In the home health world, it's also doctors and nurses that are working together, and ARMPs as well that are working at home health. So home care is much different because it's considered non-medical, and I think those are the folks that are, home care aides are licensed or certified by the Department of Health under the SEIU's initiative, and they do not have the medical certification to be able to do that. But in some home care agencies, I believe they do contract out for like telehealth monitoring. So a family may say, well, we want our loved one here to have the telehealth monitoring, but that would still go through a nurse or a medical facility of some kind, and not to a home care agency that wasn't licensed to do healthcare.
Great, thanks, Leslie. So just to summarize, your questions are, is remote monitoring, I think it's the term we often use, is that currently reimbursable under the two telehealth laws that passed here in Washington State? And then it's just an offer to have a presentation in this group about palliative care and telemedicine, and then kind of a question about how do we bill for palliative care via telemedicine. Okay.
And also the facility issue. Home health and hospice agencies a lot of times do have a base that they do their work out in the home. So I don't know how the billing for facilities fee would work on that. Would their, like Providence Home Health and Hospice has a location here in Olympia. Would they be able to charge a facility fee for home health and hospice even though they're offering the services in the home? A little more clarification around that would be helpful.
Let me answer your first question, because I think I know the answer, is that remote monitoring based on the laws that were passed, 5175 and 6519, is not currently reimbursable in the state. And it's not reimbursable for Medicare either. I'm only aware of one state in the whole United States that does reimburse for remote monitoring, and that's the state of Mississippi for diabetes care. So blood sugar, and you're mailing in your blood sugar results, or you're uploading the results. They did a pilot there that showed it was massively cost saving. So that's the only state I'm aware of. If you have members who would be willing to share their experience, that would be great. I can share our experience at the University of Washington. We did a pilot with heart failure that, again, was super successful in terms of keeping people out of the hospital, great satisfaction, but we didn't have that reimbursement at the end of the project. I know Kaiser does a ton of this. So Chris, maybe we can each have 4 or 5 slides next time or the time after that, because this is an example of one of the purposes of the collaborative, which is to bring forth, examples of telemedicine that's not currently reimbursed.
Yeah, I'll add a little, just an off-the-cuff commentary that I think there's lots of use cases where monitoring is great. To me, monitoring is not actually the value, it's what you do with it, right? Naked data is used. someone's got to analyze it and make a decision. So I think that's where I'd be interested in talking about the value and how do we think about that. I would worry a little bit about monitoring can happen for sometimes good reasons. We practice in the hospital, up in the morning, the patient's on oxygen with oximeter. Why? Well, please take it off. So things can get monitored that may not need monitoring, so I just worry about that space and make it real value. But I think there are spots with real value. This is an area we have to be very careful about.
This is where apps sometimes come in to play. So I'll give you an example of, we have a surgeon who's developed an app for post-surgical wounds, and patients are using it and taking pictures of it. But it's not clear what's the medical legal responsibility of that. And like, say if the technology breaks, is it their fault or is it the app's fault? What do we do when we have our 500 diabetics uploading 10 glucoses a day? You know, it's just a crush of data. So there's some downstream kind of issues that I know my colleagues have really said, let's stop this whole on here before we figure this out. But great, thank you very much. Anyone else who wants to ask a question for the group or? Anyone on the phone? Make a comment? Well, great. So just in terms of our next meeting, I've reached out to Mark Lowe. I don't think any of you have met Mark in person, so I wanted to give that opportunity. Mark is a pediatrician and is our new representative from Seattle Children's. And we're looking at some times in August. I know that's not a great time for many people going on vacation, but we hope that we can at least get some of you. I would like to talk about training for doctors. That's something that I've been trying to develop here at the University of Washington, and I'm very happy to share what we're doing because kind of my guiding light is Senator Becker's question: how do we keep doctors out of trouble? And I think good training before they ever do a first consultation is probably the #1 way of doing that. So I'd love to kind of share what I'm doing and get feedback on you know, what other people are doing, and for any things I'm missing would be great. But let me open it up and see if there are still outstanding questions or things that are in our charge letter that we need to take up in the next week, 1 or 2 meetings. Anything?
This was a good meeting.
Good, great. Yeah, if folks think of something, please send the email to me. And otherwise, I think we'll end a little bit early. And I wanted to, again, just say thanks to folks at MCLAC, Micah, and the team. This was really helpful, and we appreciate your outstanding facilities here.
We appreciate you coming to Olympia.